session is on left main bifurcation. The date stamp today is the 19th August on Friday, Singapore time, 3 p.m. This event is organized by the APSC, endorsed by the Singapore Cardiac Society, APSC, the National Heart Centre Singapore. This event is EBAC accredited for CME points in collaboration with Medtronic. My name is Jack, an interventional cardiologist from Singapore, your host for today. We're also very privileged to have this live case transmission hosted out of the National Heart Centre Singapore, and we're grateful to the team working hard today. Our two esteemed speakers are respectively Professor Tan Hui Chim from the NUHS National Heart Institute. He's going to speak to a provisional strategy versus DK crush for left main PCI. What's the practical approach? Professor Giuseppe Tarantini is from Italy, and he's going to follow up with a second lecture on what have we learned from the left main trials. Our three operators today, respectively, from the National Heart Centre Singapore, as well as Changi General Hospital, Professor HO Kay Woon, as well as Dr. Benji LIM. Our imaging narrator is Dr. Chee from the National Heart Centre Singapore. We have four esteemed panelists with us: Professor Charles Chan from Gleneagles Hospital, Singapore, Professor Zheng Wu from Beijing Anzhen Hospital, China, Professor Hui from Vietnam Tam Duc Hospital, Dr. Yusuke Fujino from Japan. We're also very happy to have two of our junior interventional in-training consultants, Dr. Ke Yen San and Dr. Lim Fang Yi, helping us with the live case transmission. A bit of disclaimers. This content is copyrighted by the APSC. The views and opinions expressed belong solely to the faculty and do not necessarily represent those of the APSC. This content is currently made live stream by Wonder, APSC Facebook and YouTube pages. CME points will be submitted for those who are connected throughout the full Zoom duration. You will then receive your certificate of attendance upon completing a survey sent by email. For those who are dialing in, please click onto the Q&A box below, and we'll endeavor to answer all those questions that you have. Let me state the learning objectives for today. One, we want to share lessons learned from contemporary left main PCI trials. Two, we want to discuss the practical approach between professional strategy versus a two-stent approach for left main PCI. And we want to base all these points on the live case-based discussion format. So let's get started. And I'd like to welcome Professor Tan to give his opening lecture on the practical approach to professional stenting versus DK crush. Hui Chin, please.
Thank you very much, Jack, for the introduction and this opportunity to speak at PSC CME session. Can you see my slides?
Yeah, we can see very clearly and hear very well. Please go ahead.
So since this is a fellows course, I'm going to give some practical pointers with regard to the strategy choices for treatment of patients with left main stenosis. This is where I work in the National University Heart Centre. And then we all know that when you deal with PCI of the left main, there are unique challenges. You have to consider the vessel shape and sizes. Oftentimes, we know that coronary artery divide in a fractal manner. So when you have a left main that bifurcates into LAD and the circumflex, you're going to have a change in terms of the diameter. There are also significant variations in terms of the bifurcations and lesion anatomy, and as a result of which we have to consider various things: the possibility of side branch closures or need for maintaining patency, the plaque distribution patterns, the lesion morphology, and also the angle between the main branch and the side branch. Finally, during the left main PCI, we can expect complications as well, such as plaque shift or dissection and perforations, which may complicate the procedure. So there are unique considerations in PCI of left main artery. The left circumflex side branch has a very large reference diameter and angulated, and sometimes it can be very difficult to access with your guide wire. The bifurcation angle of the left main stents affects your implantation technique. I always say that the implantation technique is really morphology driven. The acute occlusion of this side branch, which is left circumflex here, can result in considerable ischemia. And left mean is the only bifurcations where the proximal main vessel actually originate directly from the aorta. And this can increase the complexity, especially when you have these interactions with the guiding catheter and the potential for the guide wires to go between the left main stent struts. Now, this is a snapshot of the left main anatomy that you should know. The angle between the vessels for LAD and circumflex is usually about 75 degrees, and this is much larger than all the other bifurcation lesions of LAD diagonal, circumflex, RCA, and so forth. The size of the left main in general is between 3.5 to 4.75. Seldom do you have a left main that is smaller than 3.5. I would imagine that 4.0 will be the commonest diameter. And when you look at the anatomy of the bifurcation of left main, you could have a situations where it is less than 70 degrees, which will mandate a certain approach. You could have a bifurcation that is more than 70 degrees, in which then the precise positioning of the stent at the ostium of the LAD becomes possible. We know that from the XL trial and from many trials that many of the locations of left main disease actually occurs distally. So 80% were found to be distal left main disease in the XL trial. And when you have distal left main disease, you can almost expect the LAD involvement in 90% of cases. So this is Iver's findings. You can see that when you have a concentric distal left main extends into LAD in 62%, or you have an eccentric left main, you can extend the LAD in 14%, or you can have just isolated LAD extension without circumflex involvement. So when we talk about left main bifurcation PCI, there are basically two approaches that we all talk about: provisional versus a two-stent strategy. And I want to take leave from this Asia-Pacific consensus document on coronary bifurcation intervention, spearheaded by one of my colleagues, Dr. Lopui Huan. And in this Asia-Pacific consensus document, the first consideration with regard to the strategy of a left main PCI is to determine the clinical relevance or clinical significance of the side branch. In this context, we want to look at the anatomical, the functional, the clinical, and the prognostic relevance, whether it is worthwhile even considering any sort of protection of the side branch. Now, if you have a side branch that you consider significant, then you want to ask yourself next question: is this side branch at risk of compromise when you do a main vessel stenting? If it's not at risk of compromise, then just go ahead and do your provisional stenting. It's up to you whether you want to protect the side branch or not. But when you have a side branch that is at risk of compromise, then you next ask yourself, is this side branch easy to access or not easy to access? Is it suitable for two-stent strategy or not suitable for two-stent strategy? When you have a side branch that is at risk of compromise, but it's not suitable for two-stent strategy, then nothing to talk about. Just go about with your provisional approach. Perhaps you want to adopt a keep it open, do a gel balloon or something like that to keep it open. But when you have a side branch that is at risk of compromise and is suitable for two-stent strategy, you can do a provisional approach or you can do a two-stent approach. So in this context, how do I choose between provisional and two-stent strategy when it is suitable for two-stent strategy? And then I'm going to take you to the next leaf here from Dr. Rapp, who gives this a very good algorithm for left main intervention. When your left main intervention is a complex one, and by complex stenosis, he defined it as side branch lesion of more than 70%, lesion length of more than 10 millimeters. This is a lesion that you might want to consider upfront two-stent strategy. But when you have a side branch lesion that is considered simple and it's easy to access, then perhaps you can consider a provisional approach, and this will be the EBC consensus strategy. Okay, but if the side branch is easy but difficult to access, maybe you still want to go ahead and do your two-stent approach. So what is provisional strategy for provisional stenting? By definition, provisional or conditional stenting should be defined as the use of stents limited to those conditions and cases in which the operator, despite an aggressive balloon angioplasty technique with large balloon and high pressure, has been unable to obtain a result that ensures optimal chances of early and late patency. So provisional strategy, you can consider it as a technique. Some people consider it as a philosophy, where it is not one over another, is rather an approach. Provisional stenting is characterized by the fact that it is simple, it is fast, it's got excellent short-term and long-term results, and it reserves all the other options in case of failure for two-stent strategy. More than 60% of left main bifurcation can be treated using the provisional technique. And this is a step-by-step provisional technique, which I don't intend to go into details, but suffice to say, you will always size the stent according to the daughter vessels, and you will finish it with a port technique. Whether you want to do a kissing balloon inflation at the end of it or not, it's up to the operators. The data at this point in time is unclear. But side branch stenting should only be considered in a provisional approach when there is significant side branch flow impairment, when there is major side branch dissection where you're afraid of a blood closure, when the disease, when the side branch is severely diseased and large enough to possibly lead to significant residual ischemia, or where you think that the future access towards the side branch may be important, then this is a situation where you might go out to do a provisional or build up side branch stenting strategy. And if you decide to do a build out second stent strategy, two-stent strategy, actually you can use the following technique. You can use TAP, you can do the reverse crush, or you can even do the keloid as well. All of which has got its advantages and disadvantages. But I would say that TAP is probably the easiest to perform for a build out two-stent strategy. Keloid will ensure a complete coverage of your ostium. So these are the cartoon depicting the various steps in which you can do a rescue two-stent strategy. Now, if you just want to keep the side branch open, then you can consider this gel balloon technique we call. And there is a classical gel balloon technique where you simply just put a balloon into the side branch while you deploy the stent. So when the stent goes up, after the stent is up, you can actually dilate the side branch with this side branch balloon and then withdraw the side branch balloon and then do a port for the main vessel stent. So that's the classic gel balloon technique. It will just keep the side branch vessel patent. However, there's also a Dr. Saito technique of a modified gel balloon technique where you simply just position the balloon at the ostium of the side branch without going into the main vessel. And that is also good enough to keep the side branch patent. So this will be a classical case of a simple left main bifurcation, a provisional approach. You can see that this patient clearly has got the distal left main extending into the ostium of the LAD artery. So you just simply put the stent across, whether you want to protect or not. Here, I didn't think that it was necessary to protect the side branch at all. And then you just deploy the stent, you do a port technique. You can, after that, withdraw the side branch wire, and this is the final result. So a very simple approach, provisional approach to a simple left main bifurcation lesions. So this is the other view, a little bit of a coronal shift. But this is in contrast to a two-stent strategy. Now, two-stent strategy, probably the most widely evaluated two-stent technique at this point in time is the DK crush stenting technique. And I'm not going to go again to the details, but suffice to say it is a 7-step procedure where you actually have to observe every step in a very meticulous fashion. And when you employ a DK crush technique, you are strongly encouraged to do intravascular imaging as well. The difference between DK crush and the standard classic crush are as follows. There are 2 kissing balloon inflation steps involved. We recommend a minimal crush segment instead of the entire stent protruding into the main vessel. We also talk about sequential crush with a port technique. So you take a balloon that is sized to the daughter vessel, then you to do the first crush, then you take a balloon that is sized to the left main to do your sequential crush. And then we also emphasize the need for the passage of guide wire into the side branch proximal cells to avoid any missing of coronal coverage. The advantage of DK crush technique in left main stenting are as follows. It is effective techniques for complex left main bifurcation lesion, Medial 111 or 011. It preserves the coronary anatomy. The side branch access is ensured, unlike a classic crush where in about 10% of cases, you may not be able to cross into the side branch. Because with the initial DK initial kissing balloon inflation, you only need to pass your wire through 1 layer of stent strut. And the other important point here is that in the entire procedure, the guide wire in the main vessel remains in position. However, this technique cannot be performed as a provisional strategy, and there are multiple learning curves, and not many operators do this procedure. It is recommended that when you do DK crush, you want to do intravascular imaging before, during the procedure, and after the procedure. During the procedure, we will ask that you check the position of the guide wire in the proximal cell as you cross into the side branch to perform your first kissing balloon inflation. Now, so when do I consider a lesion that is complex? So the Dr. Chen Shaoliang from Nanjing, the DK Crush group, has identified this scoring method for defining a left main lesion as being, or any bifurcation lesion as being simple or complex. So the definition trial criteria includes either one major criteria plus two minor criteria. Now, specifically for left main, the distal left main bifurcation side branch has got to be more than 70%, side branch lesion length of more than 10 millimeter, plus any of the two of the 6 minor criteria, and that will qualify for a complex left main bifurcation lesion. And when they subject this complex left main bifurcations lesions patients to a two-stent strategy versus a single-stent strategy in the definition trial, we can clearly see that a two-stent strategy in complex left main, complex bifurcation stenosis results in better outcome: target lesion failure, cardiac death, target vessel myocardial infarction, and target lesion revascularization. However, in a 3-year follow-up, you will notice that majority of the benefits were acquired in the first year of follow-up. After 1 year, the curves pretty much stay parallel to each other. So most of the benefits of a two-stent strategy in the bifurcation stenosis, PCI, seems to be acute and early. So this will be a typical DK crush case when you have a 111, where you have severe disease in the left main, long circumflex, LAD stenosis involvement. So that was the let's go through again, see whether it looks good. So this was before, and this was after a DK crush technique. Very nice restorations of the normal left main anatomy. This is a second case of a DK crush, very complex again, 011. Again, you see very terrible disease in the LAD and circumflex. And this is a sort of the disease that results that you would expect from a DK crush technique. Takes a while to do this, but I think the results is oftentimes very, very satisfying. Now, this differentiations of a left main lesions into simple versus complex is actually well illustrated in the DK crush 5. In the DK crush 5, where you compare a provisional approach to a two-stent strategy in patients with left main bifurcation, for simple lesions classified using the definition trial criteria, there was no difference. But when you look at complex lesion, then this strategy of two-stent DK crush becomes evident. Okay, so when you do when you encounter a complex lesion, doing a two-stent strategy gives you a much better outcome. So my conclusion, as far as the practical approach to left main bifurcation PCIs are as follow. The stent treatment of true bifurcation left main stent coronary artery disease is now safe and effective with very low stent thrombosis if you do it properly. The provisional versus two-stent treatment strategy should be individualized according to the lesion morphology, as always emphasized, and that must include an assessment of the complexity of the left main disease. And finally, the choice of a provisional versus two-stent always depends on 3 things: the operator's knowledge, the operator's skills, and his experience and judgment. This will always oftentimes result in the best possible outcome for patients undergoing left main PCI. With that, thank you very much for your attention.
Thanks, Hui-Chin. Thanks a lot for the excellent lecture. It really set the stage for today's session. Maybe we have 10 minutes. I'd like to go around my panel to get some Q&A going. There's already a question from the audience, actually. He asked, if you just want to do a provisional approach, is it good enough just to put a gel wire approach and keep it simple? I think everyone just want to keep it simple in the professional approach. I'd like to ask Professor Zheng Wu then, in China, for the left main location, do you do just a gel wire approach, or do you routinely use a gel balloon approach to protect the side branch? Professor Zheng Wu, if you can unmute yourself.
Yeah. Thank you for your question. I don't think it's a quite wise decision to use only a wire gel in left main bifurcation, because the left main bifurcation is a big bifurcation. You can call it the third ischemia always can induce a very dangerous result. So Maybe the patient have positive ischemia burden in the circle. We will choose the two-stent strategy, or at least use gel balloon. I don't think the gel wire is a wise decision in this situation. Thank you for your question.
So a very low threshold from what I'm hearing for two-stent strategy. Dr. Hui, in Vietnam, do you necessarily do a left main nowadays as an ad hoc, or do you need to further discuss with the patient before coming back to do a left main PCI nowadays in Vietnam?
Thank you, Jack, for the question. I have to say that by my experience, is left main is almost never an ad hoc PCI. So we seldomly put it as an ad hoc procedure. So let's say if we have a complex left main with big circumflex, then I think the two-stent strategy is an upfront procedure. And then because of the complexity of the procedure, then discussion with patient is, I think, is very, very important because we always want to know how is the APT therapy after that, and then if patients can flow a long term of the APT, is there any risk factor for a bleeding in the near future, or if patients do need an urgent surgery after our procedure. So I think to be safe, left main PCI should not be an ad hoc procedure.
Okay, should be discussed, and I think surgery or surgeon should always be consulted pre a left main procedure. Dr. Yosuke, from Japan, I know you guys use a lot of imaging. Hui Chim actually showed IVUS looking at proximal crossing for DK crush. But what's your practical advice on imaging from Japan in terms of do you use OCT or IVUS routinely, and what is your preference?
Thank you for your questions. In Japan, we like to do the imaging modality. Mostly the operator use IVUS, like 80%, I think, in Japan. But sometimes we need to check the guide wire the position by OCT, 3D OCT. So some institutions try to find the result of the KBT or the stent position or something like that. In this situation, we need to do the OCT because of the high quality of the image. So in Japan, we use the IVUS 80%, maybe 20% OCT. This is our strategy to the left main bifurcation.
Thanks, Dr. Giuseppe. So still IVUS predominant procedure, particularly for the osteo location. Charles, you're the most senior among us here. You heard Hui Chim talk about the APSC consensus and the European consensus. What is your practical approach for left main PCI in general? Charles, if you can unmute yourself first, Charles. Charles, do you mind if you unmute your...
Yeah, thanks, Jack. I think that basically, I think left main, I think is a complete different sort of ball game. I think if when you do left main bifurcation, I think that, you know, we have to be very careful when we select our stent because there can be quite a discrepancy between the daughter vessel, like the LED and the circ, and the diameter of the left main. So you can get caught on this and find that actually your stent, you can post dilate to 4.0 or more, you see. So I think that's very important that we should, when we choose our stent, we have to make sure that we know how far we can post dilate the stent to maximize the size for the left main. Personally, I use either DK crush or culotte. I was quite familiar with initially quite familiar with the culotte, and I tend to be the preferred my friend's technique of choice. But recently, looking at the data from Dr. Chen from China, I'm been swayed to go more towards the decay hush nowadays. But I think like Wei Chim said, I think that you have to be very familiar with the technique, whatever technique you choose, and you have to make sure that you get a perfect result at the end.
Thanks, Charles. Wei Chim, I wonder whether you can take some of the questions before you go to the cath lab. As you can see, most of the questions are very practical fellows type of question. Maybe the first one is, when would you consider a LV mechanical assist device doing a left main standing, which type of scenario? And maybe you take that one first before the second question.
I think the simple answer here is that you will consider mechanical support in high-risk cases, particularly those with impaired left ventricular function, where any form of ischemia is going to be poorly tolerated in this patient. And also when if the lesion morphology is really complex, where you may be dealing with CDO or calcified lesions and so forth, where you might somehow compromise the left ventricular flow and so forth. So I would consider if it's left ventricular impaired or when it's highly complex lesion.
Okay. And the other questions from fellow is the type of wire that you use to recross for two-stand strategy, I presume. Is it the same wire? Is it a new hydrophilic wire? Or and how do you actually shape it? Any practical tips?
No, I think you can use whatever workhorse wire that you're comfortable with. I don't particularly go for hydrophilic guide wire. I still prefer my usual either a run-through or BMW guide wire. How you shape it depends again on the anatomy. There are situations where you can where the angle is so acute of the circumflex that you may even have to consider reverse wire. But for the most part of it, a usual curve will be able to take it to down the side branch circumflex wire.
Any last comments from Giuseppe? You have any comments before you go to the live case at all?
I think, the lecture was really bright and complete. So actually you have touched the vast majority of the points, and during my lecture, I will go through other points. So I think I'm satisfied.
Thanks, Giuseppe. So now maybe we move on to the cath lab. Then we'll use a live case to talk about all the points that Wei Chim mentioned. Can we, oh yes, we have our two handsome operators here. Kay Woon on the left and Benji on the right. Kay Woon, I'll say hello to everyone.
Hi, Jack. Can you hear us?
Yes,
Yeah.
Can hear you loud and clear.
I'm Kay Woon. Together, I'm with Benji today to do the case. We also have Chee to help us on OCT, and we have Sister Tina also involved in the case. So without further ado, I think we have an interesting case today to demonstrate left main bifurcation stenting. We can maybe transit over to the history slides.
Give me a minute, Kay Woon. Just let me bring out the slides to share. Okay, are you able to see my slides? If you are, just go ahead.
Okay, so today we're going to have a left main bifurcation case. This is a 64-year-old Chinese male with external chest pain for the past 1 year. He had a CT coronary angiogram that was done, and this shows triple vessel disease. For risk factors, he has family history of ischemic heart disease with family members dying of MI at 66 years old. He's non-smoker. He has dyslipidemia as well as hypertension as risk factors. Next. These are his blood investigations. Renal function is fine. LDL is high at 3.9. HbA1c is normal. There is no bleeding tendencies. HB and platelets were both fine. ECG shows sinus rhythm, no Q waves, and expected on echo. EF was intact with no regional wall motion abnormalities. We just show the angiogram that was done earlier. So this was an angiogram to evaluate the abnormal CTCA. You can see that there is a tight lesion and calcified together with diffuse lesions in the LAD. Okay, we're switching the views now to see the LAD, diffuse disease, and also the RCA. This is subtotal occlusion of the RCA. So this is the left side. If you can move over to the right side, this was the RCA. So subtotal occlusion of the RCA. So on table, we actually discussed with him that he has triple vessel disease. His EF was intact. He has no diabetes. We offered the option of coronary artery bypass, but he adamantly refused bypass. So at that session, we PCI'd the RCA, and the RCA results was shown in the previous angiogram of the RCA. So maybe, Jack, we can discuss about the strategies.
Yeah, thanks, Kay Woon. So this is today's case, not an uncommon case you see in the cath lab. Syntax score 24, low has blood score, fairly young, non-diabetic, normal EF. Hui, is this the case that you take off table to discuss, or you think it's good enough for you to move ahead for PCI?
Thank you, Jack. Thank you for showing a case that is, we have to say that is not uncommon in our daily practice now. But first of all, we have to totally agree that this is a trivial disease, left main with trivial disease, and bypass is always first option. So I think that it's fair enough for patients. If we talk about the bypass first for patients, family, and then a discussion, I think an open discussion should be taken between doctors and families and patients. But as usual, as any Asian patients, so I think persuade patients for bypass surgery is not easy task for us. And then our patients almost prefer not doing surgery if possible. So I think RCA should be the first lesion to be taken, and then already done as a beautiful job of the team. So regarding left main PCI, so I think it should be maybe the next step of PCI for this case, and then I think this is a true bifurcation lesion with a big sub, and I truly don't want to lost this left circumflex during my PCI. So maybe two-strand surgery upfront will be my choice for this patient.
Thanks, Hui. Dr. Giuseppe, maybe I'm jumping your lecture a little bit, but in Europe, looking at this anatomy, is this a EBC type provisional patient that you can consider, or is it a two-stent patient?
Yes. If you participate to the EBC trial, yes, it is possible candidate for EBC. But actually, in the normal practice, it's not so far from what I've heard among our friends and colleagues, because in this case, we have to admit that if the patient is not diabetic, this is very important, actually the distal vasculature is very easy to be grafted. So the recommendation is 2A for PCI, remaining 1 for cabbage. So also in Italy, in Europe, you have to discuss first with the surgeon. In this case, we have a patient refusal, and we are supposed to go for PCI. But actually, in this case, what is important is to make not a blinded PCI, but an IVUS guided PCI, because the final PCI optimization matters a lot in terms of outcome, especially at long-term outcome, because as you know by the Excel trial, otherwise you will see a switch, a crisscross of the curve, not in favor of PCI. So PCI optimization here is really of utmost importance.
Maybe I can get Hui Chin one last comment is that you've seen the angiogram. Do you think there's added value that will change your strategy for imaging, or just based on angiogram, you really have quite a firm strategy here? Hui Chin, you're muted, sorry.
Thanks for the question. So, Jack, I think for complex left main bifurcation lesion, which this patient's anatomy fulfill, I would actually strongly recommend a two-stent strategy backed up by intravascular imaging here. So, and I think this will give us the best possible outcome, which we always should strive for to be equivalent to that of CABG in order for this to be a feasible strategy.
Thanks, Richie. Charles, this case has pretty large circ, wouldn't you say? Do you think you can do a DK crush rather than QLOT, or is no difference for you?
I think probably this one I'll probably use a DK crush because of there's a bit of mismatch between the circ and the LED. But I think probably the most important thing I think we tend to lose is that the LED, you can look at the LED diffusing disease from the mid to distal. I mean, I don't know. I mean, we're all focusing on the left main strategy, but whether the long-term patency of the LED we need to consider, and whether, what are we going to do? I mean, are we going to stent the LED or we just leave it, just do the left main? So all this I think we need to discuss with the patient, I think.
Jake, is it possible to see again, the angio?
Yeah, we are going to go to the cath lab and see what's live now. So, Obi-Van, can you share from the cath lab, and Kay Woon, can you show us what we have today and what you are going to do?
Change over to the live angiogram.
Yeah, we are seeing the right side now, Kay Woon.
Yeah, so this was the stents that Jack, you have stented, still working very well. No early restent restenosis. Then we'll go on to the left. So this was the diagnostic shots. Areocranial, again, like what Prof Chan has said, diffuse LED disease, right down to the distal. And the spider, you can see tight lesions in both osteo LED as well as the circumflex that's calcified. Next. In the areocaudal, you can appreciate the tight calcified circumflex stenosis. Fortunately for us, the rest of the circumflex relatively disease-free and large. So these are the images. Maybe we could get everybody to discuss their strategy.
I think a lot of the folks actually mentioned that they'll go with two stent, and Charles was concerned about the long diffuse lesion in the LD. Maybe you'd like to share with us what you've done so far and your strategy that we can discuss with the panel.
Sure. So I'll go step by step to show what we have done so far. We have wired the LED. We wanted to image, but we were a bit concerned about using OCT and a lack of opacification of the contrast. So we pre-dilated with a 2.5, and the OCT pullback was done. At this juncture, maybe I can get Chee to share the OCT run of the LED. We switch over to the OCT event.
Okay. While waiting for the OCT to show up.
So OCT for the mid-proximal LED segment, yeah. Yeah, we
okay,
can
so
see the OCT now.
Yeah, so this is our OCT run from the distal edge of the disease in the mid LAD. So maybe I'll just show you from the proximal end. So here we are in the left main. This is the distal left main. Yeah. So this top right hand corner is the cross-sectional view of what we're looking at. We at this point do not have a wire in the circumflex yet, but that is the circumflex over there at the 9 o'clock position. So I have adjusted an image to position the circumflex at the 9 o'clock, and you can see how I can adjust that by going to settings and going to the rotation. And I like to do that when I'm assessing the left main to LAD so that I know
left
circumflex going to the...
Then we put a stent with it.
Yeah, circumflex to the 9 o'clock. So diagonal branches will also go in roughly the same direction. And the septal branches will go down about 6 o'clock position. So we know and we can orientate ourselves to what branches we see later. Okay, so I've orientated that. And now we'll maybe assess from the distal to proximal. So this is after pre-dilatation, so it's important to bear that in mind. So we'll expect to see some dissections. This is at the distal part of the vessel, or rather distal to the lesion. And fortunately, we have a relatively normal looking segment over here. So there's only thin amounts of intimal proliferation. So relatively healthy vessel here. So that's good for us in order for us to land a stent if we were to choose to stent. And so moving more proximally now, we start to see all these dissections, which are iatrogenic, caused by our 2.5 balloon dilatation. So a lot of dissections, which we expect to see.
Wait for let's do.
So this degree of dissection is acceptable. At this point, it's hard to tell after balloon dilatation, but mostly soft kind of tissue, fibrous, some lipidic maybe, plaque. Not a lot of calcium at this point. Moving more proximally now, we see maybe a chunk of calcium over there, not very large, and certainly not circumferential. Still a lot of dissections. This is a branch going down to the 6 o'clock position, so we expect that to be a septal. This is the large septal branch. Okay, this is the angiocore registration image, and we can see on this it helps us to orientate ourselves to where we are in the vessel as we are pulling back on the OCT. So all the way there's a lot of dissections. Here there's a little bit more calcium, but the calcium looks like it's broken, so it's not like a continuous block of calcium all around. Moving more proximally, still mostly fibrous, a bit of lipidic plaque, not a lot of calcium. And this is the high diagonal. This is the very proximal LAD, and that's the circumflex again. Okay, so on angiography, I think we can see some shadowing, some hints of calcium. This over here in the very proximal LAD, there is maybe 180 degrees, just about 180 degrees of calcium. If we measure the thickness of this calcium, it's going to be more than 500 microns. But overall, the appearance of this vessel, appearance of the calcium in this vessel doesn't look so extensive. So if we use the OCT calcium score, although it might score 2 or 3 points out of 4, I don't think that we need to do any calcium modification for this proximal LAD. So hopefully with high pressure balloon dilatation, that will be sufficient. So in summary for this LAD, diffusely diseased all the way from the mid left main, from ostial LAD all the way to the distal. There is a landing zone distally for stenting. Yeah, so probably can get away with stenting, and hopefully it'll give us a good result for the LAD.
So Kevin, you're going to show us more segments or?
Yeah, so if OB Ben can switch back to cath lab angiogram. So we started where OCT have just finished. This is the short after OCT run and pre-dilatation. We are concerned what we should do with the distal LAD. He's relatively young, whether in the future with the patency of the stent means that we need to consider bypass operation. So consideration includes drug-eluting balloon or stenting of the distal segment. But we felt that there was too much dissection. Even on angiogram, you can see this hazy appearance. So we decided to go with stenting. There is still a landing zone for Lima in the future, even with the stent. So this is an Onyx 225 by 38. Further post-dilated. Okay, so this is what we did to deal with the distal part of LAD. Any comments from the panelists?
So can we make a comment that based on what you saw is a straight stenting case? Charles, would this be possible for DCB approach actually? It's long diffuse, not very heavy calcified.
I won't be too keen to do DB, just only. I think I will probably, because if I'm thinking of doing left main, I'm have to make sure that my distal LAD distal flow is perfect. If we are considering to do the distal left main stenting, you know. So you're talking about DB or DCB?
Yeah, DB for the LED segment.
That's right. I think that, because, I think the DB, I think, the only attraction is like Kay Woon was saying that you don't have a stand there. But I think for future Lima, but I think that you want to have a good immediate results, and the only way to guarantee that is to do stenting. Yeah.
So Kay Woon, I noticed you already pre-dilated the osteocirc as well. Is that correct?
At the OCT to decide what to do with calcium modification, it didn't reach the criteria for severe calcification, so we didn't opt for any rotor ablation or IVL. This is using an NC Scoreflex 3.0. We dilated both the LED ostium as well as the circ ostium. So this is where at the moment that we are. We're going to concentrate now on the left main bifurcation and starting with the DK crush.
Okay, so your strategy will be a DK crush like what most of the panelists spoke about for this case. So maybe you can take us through step by step on the DK crush approach here. And
so we've wired both branches and prepared both with pre-dilatation using the NC Scoreflex. This is a 3022 onyx stance that we are positioning in the circumflex. We are positioning that it is slightly protruding into the left main. We have an NC35 balloon that you see in the LED that will be used to crush the circumflex. So this is going to give a small path now.
So the faculty feel free to jump in for any tips and tricks at any point. Hui Chim, can I ask how much do you protrude actually for DK crush approach?
I think we recommend between 2 to 3 millimeter of stent in the main vessel. So I just want to ask, is the 3.5 millimeter balloon IVUS guided? So is that the size of the LED approximately?
Approximately LED, yes. Yeah, Chiang is
yeah, the proximal LED, of course, is heavily diseased, so we can't tell for sure. But the distal left main lumen, the lumen size is about 3.3. So I think 3.5 will certainly achieve, well, hopefully anyway, achieve good crushing.
Yeah, in general, we like to take the first balloon to crush at using the size of the LED. So,
yeah.
Okay. So carefully positioning the circumflex stance. I think this is a relatively good position. What does everybody think about the position of the circ?
Is your balloon in position also? Or?
The balloon is in the mid LED. Yeah, we can always pull back that in. Okay.
So Kay Woon, I noticed you are going for very minimal protrusion. Yeah.
Yeah.
Is that correct?
Yes, I was involved in another case that had more protrusion. We'll tell you about a nightmare case later on if we have time, but we're going for minimal protrusion. Yeah, like what Prof Tan said, about 2 or 3 shots. If everybody is okay, we're going to deploy this. Going up.
So can I ask the operator? So is there any tricks of using the 2 balloons? If we see the 3 dots in the same line, 2 dots of the LED balloon, and then the dot with the proximal of the stent in the left circumflex, make sure that we do miss the ostium of left circumflex.
Kay Woon, did you get that question? How do you actually position to make sure that you don't miss the ostium? Because sometimes it can be too close.
I'm selecting a good angle to have a good spread between the circumflex and LED. There are also tools that we can use like stem rules to help us gauge the position accurately. Yeah. So those are, but mainly finding a very good angiographical angle that spreads the LED as well as circumflex. In this case, the spider seems to be a very good angle for this.
So now you're going to optimize the ostium of the circ before you crush it, right?
Yeah, we have pulled back and gone up to 16, but based on OCT, it is 3.3. So we're going to take a 3.5 NC to optimize the stent. 3.5 NC.
Jim, is that what you usually do as well? You optimize the ostium before you crush it?
I think that will be a good thing to do. So give it the best possible shots in terms of expansion and apposition.
3.5 NC. I mean. Yeah, so just getting the equipment.
Dr. Yusuke, in Japan, if you use this approach with OCT, do you necessarily always recheck the recrossing later before?
Yes, in this station, actually, we need to check the osteal information of the circumflex. And maybe if I use OCT, I want to do the OCT pullback from the left main to the LAD and both circumflex to left main, because after that we check the ostium information after the implantation. And sorry, I can't hear the comment from the chairman. Sorry about.
Thank you.
Sorry.
Maybe we could switch over to Chee Yang. Yeah, so we'll show you the OCT images while we optimize the circ stent.
Yeah, so that's a good point. I think whenever you're dealing with the left main, you should do the pullback from both the LAD as well as the circumflex. So we did do that, but I didn't get the opportunity to show you the findings from the circ. I think you have the OCT screen on now. So we'll just quickly show you the circumflex pullback. So this is from the relatively healthy segment here in the proximal circumflex. If you go more proximally, there is some fibrolipidic kind of plaque. The vessel becomes a little bit larger here in this bulgy part here in the very proximal, before it becomes diseased again. There's some evidence of calcium over here, but certainly not circumferential. Here, there's a bit of calcium at the superior part and the inferior part. But as I mentioned earlier on the LAD, it doesn't seem to be continuous. So this kind of calcium should normally be quite easy to split apart. Okay, and here's the very proximal circumflex entering into the distal left main, where you see the second wire from the LAD. Yep, so we already did our measurements earlier, and that's how we came to the sizing for the stent for the circumflex. So yeah.
Thanks. Jim, just how you made the comment, your crushing balloon, Kay Woon parked it quite distally. Do you park it right across the left main usually?
Most of the time, you don't have to park it across the stent because your circumflex stent diameter is clearly smaller than the left main. There will always be gap in the left main between the left main's vessel as well as the stent struts. But if you're concerned, you can always park it across. But usually I just park it across so that I complete the procedure quicker. So what I'll do is I'll deploy the stent, pull back, go high pressure, take out the balloon, and then I'll crush it with the balloon that is just parked across the stent. But you can do it in any way because there will be a gap between the stent and the vessel wall.
So in this case, you will size the crushing balloon to the left main diameter?
No, LAD first. So we always size it to the daughter vessel first. And then you take a larger short balloon to do the sequential crush, or you call it a port, whatever.
In this case, Kay Woon, what size is this crushing balloon?
Have an NC35 in the LAD. We're happy with the optimization. There is no distal dissection of the circ. So we're going to crush. We have the circ wire taken out. We have the position 3.5 NC balloon across the stent. We're going to take the next step to crush now. Okay. Waiting.
Charles, do you usually also remove the wire before you crush?
I don't think it makes any difference, really. I mean, you know, you can just leave it there, or you can crush it. I don't think I had any wire which was crushing the stent. I would have used a 3.0 balloon actually rather than the 3.5. Not sure whether the the LED was actually 3.5 vessel. But anyway, you're going to stent the LED in any case. What I'm a bit concerned about is that you see the proximal part of the left main is more than 4.0. So I'm wondering what sort of stent are going to use. Are you going to cover all the way to the ostial left main, or where are you going to park your stent in the left main? Kay Woon? Yeah.
Yeah, so it's actually a long disease. We are planning for another 38 stents. So it's important to know the expansion limits of the stents. We're planning to base it on the distal part, which is the LAD. That is about 3.5. So with a 3.5 onyx stents, we can actually post dilate to 4.0 if there 4.5 if there is a need to in the left main. With a 38, I think we will just cover the calcification part within the left main. We're hopeful about that. So next step is to recross after we have crushed the stents in the circumflex.
One of the things that we don't do actually for most of us is actually we don't pull the wire out of the circumflex as yet during the crushing, because this wire will serve as a guide for your recrossing of your new wire. So by staying as close as possible to the trap wire, you know that you're going to go into the proximal cell rather than the distal cell. So that's why most of us will just leave the wire as you crush the first stent. Also, the chance of this wire being trapped is very low because the amount of metal that is being crushed that is entrapping the wire is very little. So you have no concern as far as the wire being entrapped by the crushed stent. But you will provide a direction by which your new wire will go down.
Probably one suggestion is to avoid hydrophilic or polymeric wire in case you want to gel the wire, just to avoid the peeling off of the coating.
Would you like
Benji skillfully wire? Any advice for the fellows? Where do you aim for recrossing the crush stent? Proximal, distal, or no preference?
One of the things that we will do is we will do a port first. We do a sequential crush, take a larger balloon and crush the proximal part of the stent in the left main, and then pass a wire as close as possible to the proximal cell. But right now, you will just have to direct the wire as close as possible to the left main bifurcation, because you have no more guides from your first wire.
With a 3.5, there was some indication that from the EBC to use a pot crush. Would you take the extra step? And if so, what size of balloon would you use for the pot crush?
Using your OCT guidance for the left main. So left main was about, I don't know what size, about 4. I would imagine this left main must be at least 4, so I'll take a 4.
A short 4.8, right? A short, yeah.
So that will facilitate the entry of the wire into the side branch too by opening up the stent valve.
Any other tips and tricks from before we transit to the second lecture first? Kay Woon, it's quite nice to see you doing it step by step actually. So far you have done appropriate sizing using intravascular imaging. You prepped the distal LED, you sized it to the daughter vessel in the circ, and then you have optimized the ostium before a crush. Which advised actually a pot crush, so it's to facilitate entry, and most of the operators seems to have would have left the trap wire in either as a guide or extra support to recross, particularly with the second balloon as well. But I think what you're doing so far is also reasonable. With some modifications. So you've shown that it can be done. Which step are you at now?
So we're trying to going to cross the crush stent with a balloon, but I would usually place what I would kiss with in the LAD. This serves as two purposes. We can use this as an anchoring balloon if we have any resistance passing the balloon to the circ. And also it prevents me to dilate the circ without any balloon in the LAD for fear that the carina gets shifted once the circ balloon is inflated without the balloon in the LED in place. I don't know whether this is just stylistic or it's a practice for everyone.
Okay, so we'll watch you do this part first. I don't think it's necessarily any difference. I think as long as you get the first case up for DK crush. Any comments from anyone about what Kay Woon mentioned?
I just want to
Sorry, Kay Woon, which step are you at now? You're crossing with a second balloon, right?
Yeah, we're taking a 2O balloon to cross the circumflex, the crush part. Chiang has a comment also.
Yeah, Chiang, go ahead.
say that sometimes when you rewire the circ so easily, you worry whether you're actually going through the lumen of the
Benji is
stent.
skillful.
Yeah. So one option, if you have time, is to image from the LED to be sure that you are in the right place. But nonetheless, anyway, we can trust that Benji's hands are skillful, and we'll go ahead.
Yeah. So you can see the 2O balloon, crossing very easily. I think related to the point of wire recrossing is to avoid the distal centroid, because if we go for that distal centroid, we'll be actually lifting the circumflex away, creating a big gap. So we are going for a non-distal crossing of the crush then. Yeah. So we have 2O position in the circumflex, dilating, 60. Use a 3-5 now, NC.
So you're going to do the first case with 3-0 or 3-5-3-5?
3-5. So it would be 3-5-3-5. We're just going to further optimize the.
Dr. Giuseppe, would it be your usual practice to do an OCT first to check the wire recross before you kiss?
Actually, I checked the OCT because of the 3D OCT can show the recross position of the guide wire. So actually in Japan, we do the study, the 3D OCT. So, but if we use the non-compliance balloon,
So we're losing you a little bit, Dr. Giuseppe. Maybe
the result is mostly same, because if we sorry, the connection, sorry, the internet is unstable, sorry, but I cannot hear everything that I could.
Yeah, your connection was a bit unstable just now. So Kay Woon, you're coming back with a 3-5 NC balloon to finish with the first
circumflex. This is 3-5. New one. I think we use.
So Kay Woon, we're going to take a pause from you and let you show us a step by step again later.
Okay.
After you demonstrate the first case perhaps and see whether you have a problem crossing now.
Okay. Yeah. So we had some resistance crossing. We did cross successfully with a 2-0. So we know that's not a problem of wire wrap. This was a used 3-5 NC balloon. So it may be just a problem of rewrap. So if it doesn't go through, we may use actually a new 3-5.
It's a 6 or 7 French system, Kay Woon?
This is a sheathless 7.5 guided.
Charles, any preference for compliant versus a non-compliant balloon for this step of a kiss? Charles, you're muted.
Yeah, I think basically I would prefer probably just use the normal semi-compliant balloon at this point. I think it's only at the final sort of kissing and part I would use a NC balloon. The problem that you see that when you use those NC balloon, they are quite bulky, especially after they've been inflated before. So whereas you can get away by the normal workhorse balloon, the profile is better. So at this stage, I think, you know, I would just use the normal sort of balloon. And then at the funnel kissing and the pot, I will use the NC balloon.
Okay. So Kevin, we're going to leave you here and
no problem.
ask you to stop share here from the cath lab. And then Giuseppe will ask Professor Giuseppe to share with us the data behind all the left main PCI trials. Giuseppe, please. We can see your slides very nicely. You can get unmuted.
Okay, can you hear me now?
Yep, we can.
Okay, thank you, Jack, for having me on today. So actually, you know, the title of my talk today is What Have Left Main Trial Taught Us? So let's get started from here. That, you know, pardon me, there is a problem here. Okay, there is a little delay. So actually, I would like to start from the guidelines. From the guidelines, that's at least in Europe, they say that a PCI for the left main is a well-established way to revascularize this patient. Actually, we have a lighter indication for the American guidelines, but actually we have to acknowledge that we are among interventional cardiologists here, but it's important to realize that there is a clear scrutiny in the left main space because the results of surgeon are very good. So this is my first point. I don't know what happened. But actually, you know, this is the second point of my background, because when we look at longer term follow-up on the left-hand side with Excel trial, as you can see, after 2 years, there is a crisscross of the curves, not in favor of PCI, with a P that is 0.1, not in favor of PCI. And actually, the last background that I would like to share is whatever is the strategy of revascularization for the left main, either CABG or PCI, actually, we might have among centers and among operators a difference in heterogeneity and a variance of 30% in the outcome. Actually, this is the result of the Syntax trial, as you can see with the taxostent, we might have, you know, a miss rate of 40% or 5%. So we have to consider all these things, because when we decide to go for PCI, we need to follow some routes that are derived from evidence to get the best result as possible in terms of mid-term and long-term follow-up of the patient. So having said that, this is my storyboard. First of all, I would like to discuss the patient selection. Secondly, I will share with you the technique, provisional versus two stents, how and what we have to know, tools, so imaging guided stent and the stent choice. All these things have been discussed during this live case. So let's get started from patient selection. We know by the ES guidelines that we have some variables that favor PCI instead of CABG, that actually is not an high complexity, anatomical complexity. So having a Syntax score less than 22 or an SCS patient or contraindication for surgery, for sure is in favor of deciding to go for PCI in a patient. But today, I think the most important focus is to discuss about the technique first and then technology. So what about the evidence? When we have to decide about provisional two-stent techniques, we have a bunch of registries, we have some randomized trial, and we have post-hoc randomized trial, that is the Excel Novel and Syntax. So actually, if we review for first the result from registry, and it is a meta-analytic, you know, results, we have, you know, at least a trend in favor of provisional stenting. Actually, we know that among registry, there is a lot of heterogeneity, as shown by the I-square, that is 62% in this meta-analysis. That means that we have different patient selection, different techniques, different stent used. But actually, the signal is in favor of provisional stenting. moving from registry to trials. So the point is that when it's better to go for provisional compared to the two-step techniques. And actually, with the post-hoc analysis of Excel trial, it is clear that provisional is superior to the two-step technology when we deal with non-true bifurcation. When we deal with true bifurcation, the result of this of the Excel trial, as compared to the EBZ main trial, is pretty the same. That means that at least numerically, we don't have so much difference. So we need to understand when to use provisional or two-step technique. And actually, again, going back to the pooled analysis of randomized trial only that include the EBC and DK crash 5, as you can see, it seems that favors double stenting, but with a lot of heterogeneity again, because the I-square is close to 90%, more than a registry. And why is that? Actually, we've seen also in the previous lecture that there are some great differences, major differences between the EBC main and DK crash 5. First of all, the technique. As we have seen in this live case, the DK crash was used in 100% of the cases in DK crash 5 and only in a minority of patients in Europe in the EBC main trial. But actually another major difference is the complexity, because in the DK crash, the SINTA score was 31 and not 23. The side branch length of the disease was 16 millimeters. Trifurcation 4 times higher compared to the EBC main trial. The side basal stents were used in 50% of the cases. So higher complexity that came along with 100% use of the DK crash. So having said that, I think is important. Now we can understand why it's so important to select the technique when we decide to go for two-stent technique. So what? So we need to recall the DK crash 3 that shows that DK crash, when compared to culotte, was superior, and this is the comparison of DK crash 3 and DK crash 5, where the DK crash stenting was better than provisional, but actually when we go for two-stent technique, we have to know that DK crash stent seems to be better than culotte. We don't have data comparing DK crash with TAP, for instance, and the absence of proof is not the proof of the absence of an effect. We need to be very fair in that. But actually, by the available evidence, we know so far that DK crash might be the way to go when we decide to go for the two-step technique. And actually, this is included in the guidelines. In two bifurcation lesion on the left main, the double kissing crash technique might be preferred over provisional or culotte stent as a 2B indication, level of evidence P. So let me go to the end of my presentation, discuss two very important points. The first one is that we don't have to go blind when we decide to go for a complex left main treatment by PCI. And actually we know that IVUS is the imaging from where we have better evidence that impact the outcome of patient treated with PCI for left main. And actually this is included also in the European guidelines. As you can see, IVUS should be considered to optimize treatment of unprotected left main 2A B level of evidence. Actually, the OCT is mainly indicated to optimize, stent implantation, but as you can see, there is no focus on left main, because actually we have to acknowledge that's what the proximal third part of the left main sometimes is very difficult to visualize. And we have some paper, Italian paper, that shows very clearly this point. But IVUS is also very important, not only to decide whether or not we have to do the PCI, but also it's very important where we have to decide how to optimize. We will see the final result in the live that we are, facing today, looking at the final MLA that we get in the proximal left main, circ, and LAD, because this impact a lot in terms of outcome. And actually using the imaging is important because may help us in the final decision towards two-stent technique compared to provisional. For instance, if we have a significant lung disease at the level of side branch with two bifurcation, we have a narrow angle, we have a significant osteo, very calcific circumflex disease, actually this prompt for the two-stent technique instead of provisional stenting. So finally, the stent, also we have discussed this point, not all the platform are the same, because actually we have just the Resolute Onyx and the Synergy Megatron that can go up to 6 millimeters. This is not true for the other stents. This is very important to preserve, the coating of the stent, avoiding the peeling off of the polymer that is outside of the stent. So actually it's a privilege to present for the second time during this meeting what was the late breaking results that we presented the Euro PCR, and in 1 week will be published in Euro Intervention. So actually the Rolex registry is the largest European registry that we have so far, 450 patients focused on unprotected left main. Symptom score has to be less than 32, and the treatment was Onyx, all the platform of the Onyx family, including the XL stent sizes, that is 4.5 and 5. As you can see, the sample size was pre-specified, also including a powered analysis of 150 patients of isolated left main. So in this registry, there was collab evaluation, and all events were adjudicated by an independent clinical event committee. And the goal was to evaluate safety and efficacy of the last generation Zotarolimos eluting stent Resolute Onyx. So what about the inclusion criteria? Severe left main stenosis, at least 70%, you need to make physiology or IVUS. In case of intermediate lesion, we excluded STEMI patients and actually dialysis patient or left ventricular ejection fraction of less than 30%. The primary endpoint was the target lesion failure at 1 year, and the secondary endpoint, all the single-digit endpoints included in the previous combined endpoint. What about the demographic? Just to show and to share with you that we're dealing with a real-life left main patients. Diabetes mellitus, 30%, ejection fraction below 50 in 1/3 of the patients. The symptom score was 24, and in 2/3 of cases were higher than 23, exactly like the live case that we are looking up to, that we are facing today. ACS 53%, distal left main 80% of the patient, true bifurcation 20%, radial axis 77%, 50% underwent, IVUS or OCT, and the total stent length was about 5 centimeters. So two-stent strategy was chosen in 1/4 of the patients. What about the outcome? 5% of TLF, cardiac deaths was 2.7%. Actually, the TLR 2%, the stent thrombosis was 1%. So 5 cases out of 5, in 2 cases, there was a premature, disruption, or discontinuation of TAPT that was not recommended by the doctor, was, a choice of the patients. Actually, I believe that this is a very important sub-analysis. When you go for the when you compare angio-guided versus imaging-guided PCI, the adjusted analysis for center, we have to recall my slide on the difference among center in the outcome by the SYNCTAS trial. So it is very important to adjust for the centers, diabetes, gender, complexity. Actually, you might see that when you decide to not go blinded for this revascularization, the outcome drop down in favor of the good outcome of about, more than 50% the outcome is better, significantly better, from 7% to 2% cardiac mortality is fourfold less. And actually the stent thrombosis dropped down from 1.6 to 0.5%. That means that, you know, IROS or OCT guided revascularization is very important. And this is just one example. If you do the QCA, the distal, the ostial LED is less than 4, but when you go with IROS, it's 4.445. And if you look in the Rolex study, the angio versus the IROS or OCT guided PCI, the proximal reference is pretty the same. But the use of 4.5 and 5 platform increase of about 51% in terms of relative risk when you use the IROS. And this is very important because you need to match with your prosthesis, you know, what is the right reference vessel of the patient. So in conclusion, PCI is a valid alternative to CABG in low intermediate CETA score and in non-diabetic patients. Provisional technique should be the preferred strategy, mostly in non-tube bifurcation. In tube bifurcation, where two-stent technique is the chosen strategy, DK crash seems to have the better results for the evidence that we have so far. Imaging-guided PCI is strongly recommended, should be recommended. And the use of dedicated large vessel stents are useful to match the final left main reference vessel of the diameter. Thank you for your attention.
Thank you, Prof Giuseppe. Again, a very practical lecture, and thanks for sharing with us the Rolex results. Any observation from Wee Chim about this presentation, particularly on the difference between DK crush as well as EBC main, and is it complementary what Giuseppe shared about the Rolex result as well?
Yeah, I think I'm pretty aligned with my thoughts on left main PCI with Dr. Giuseppe. I think in interpreting EBC main versus DK crush, you have to understand that essentially we are dealing with two different populations of patients. One is relatively simple and the other one very complex. Can imagine even CTO cases and acute MI cases are being enrolled in the Nanjing trial. So I think we're dealing with different population, and the lessons that I draw from these two different trials here, again, is that you have to individualize therapy. There is no one-size-fits-all strategy for left main PCI here. So you have to take into consideration the clinical, the morphological, and the LV function of patients as you consider your strategy.
Charles, Giuseppe actually mentioned the Rolex trial, you always adjust for diabetes, but actually the disease complexity, how much weightage do you put on diabetes as a comorbidity when you do PCI?
I think, especially in the private sector, I think diabetes, patients who are diabetic, I think we still think that the first choice is still surgery. We still think that the results of the left main stenting, even though it's feasible, but if the patient is diabetic, we tend to favor surgery. I think the jury is still out there. I still don't think that PCI, you know, is definitely not superior, but whether it's equivalent to surgery, I'm still not sure. I'm still not convinced yet.
Thanks.
So actually, I can comment on this. I think it's important that, you know, in general, as a general message, the feasibility of intervention is not the reason to be indicated this intervention. This is very important in the left main, especially with diabetic patients. As Dr. Tam, you know, said during his presentation, during this comment, actually it's important that the higher is the clinical complexity. That means diabetic or insulin-dependent diabetic mellitus. And the higher this complexity or the anatomical complexity, that means the CINTA score that is very high. We need to realize that there is a class 1 indication for surgery, and we have to think at more than 5 years. And we know also by the Freedom trial that we can increase the mortality in this patient. So, but if we decide, you know, based on many considerations, also including the patient preference, we need to be very careful to, to have a perfect angiography, to understand if what type of Medina is this patient, if it is a 2 or not 2 bifurcation, to select the most appropriate strategy, to go with the imaging guided PCI, to look at the metrics, because we need to be very extremely accurate and to follow all the rules to do our best. Otherwise, it's going to be a mess for the patient. So this is the point.
Maybe one last question from me to Giuseppe as well. You show that with imaging, you use a higher frequency of the XL onyx type stents, but most times in our Asian population, the LED is as best 3.5, and the left main could be a 6.0, for example. You are quite comfortable in putting a 4.5 or 5.0 stent across the left main into a daughter vessel, which is smaller?
No, I think it's always a mistake to overstretch too much. But actually, in Europe, it's very frequently, if you look at the distribution, the reference vessel, many times we are about at least 5 millimeters. So actually having an XL size is very important. And actually in the Rolex, we use in 21%. That is, it's not probably a minority of the patients. But actually, when you go with IOS anyway, the frequency of the use of XL sizes increase significantly, because actually compared to the angio, you have a step up, as I've shown you, in more than 50% of the cases as a relatively risky increase.
Hui, may I ask you, if the guidelines does change to say that it's a class 1 recommendation to do imaging for left main PCI, would that be something you'll welcome in Vietnam? Does it help you at all?
I think based on the data now, everybody agree that imaging should be the class 1 indications for left main PCI. But anyway, the reality in Vietnam is that because of the reimbursement, so I believe that the use of imaging in left main PCI for the all other PCI technique is less than 50%.
Okay, 50% is still quite good if it's 50%.
It's super good.
Yeah, super good. Can we now go back to the cath lab, and then we want to put what Giuseppe presented into our case again. Kay Woon, we're back with you. Maybe you'd like to bring us through where you are and what you have done so far.
OCT run, where do we left you with? Let me see.
You were going to do a first kissing, delivering a 3.5 balloon for the first kiss, I think. Yeah,
this was a crush. Yeah, this was a crush. So we wired, and we used a 2.0 balloon. I think it sailed down very well. Then we attempted to use an NC35 that was used. Then you saw the resistance. When we changed to a new NC balloon, it sailed through very well, the crush stent struts. So we positioned 2 NC3515 balloon in the LED as well as circumflex. Sequential high pressure dilatation, first to the circumflex, then to the LED, then kiss. Okay. So this was the stent. This is a 3.5 by 38. So we aim to overlap the previous stents and yet cover the left main calcification. So there was a bit. Yeah, we just cover both proximal and distal. But anyway, we will see from OCT later. Various angles, and we inflated this, removing the wire in the circumflex. So this is after stenting.
So Kay Woon, is there a pot in the left main LED first before you recross?
Okay, we didn't perform a pot in this case. We should have, but we went ahead to rewire, which was quite easy. we were a little bit more proximal in this first wire crossing. So we wanted to be a little bit more distal. The second wire crossed too distal. So we chose a third position that's somewhere distal. So you can see from this cine the position of the various wire crossing. So we have a 3-5 NC balloon in the LED. We then pass a 2-5 balloon in the circumflex. We have the 3-5 across the circumflex. We post-dilated the stretch of the LED stent with the NC3-5 balloon. Again, sequentially dilating the circumflex. And a final kiss with 2 NC3-5 balloon in the circumflex and the LED. So this is taking a 408 NC balloon for the final pot. And we're just positioning the OCT catheter.
Flash, please.
Yeah.
Flash, please.
Okay. Right.
Dr. Giuseppe, in the Rolex study, was there any observation about the ostium of the side branches on imaging achieved? Was there any data on that?
Not specifically. So actually, you know, in the IVUS guided patient population, actually there was an optimization following the recommendation of MLA that is more than 8. So actually, you know, this is the only things that was recommended. And actually, if you look at the results, the mean value was about 6.5 plus minus 0.3. So, you know, the use of IVUS got to the real optimization of the ostial of the circuit. It is the main reason why you fail in the left main strategy.
But angiographically, this looks very nice, Kay Woon. Prof Tan, do you have any advice on the steps that were shown? Any tips for the fellows?
Yes. So when you want to recross again, so after crushing the side branch stent and then deploying your main vessel stent, when you recross with your wire, this time around to a second branch, we actually still advocate a proximal to meet self entry and trying to avoid distal cell entry, unlike a keloid stent, just again to ensure that there is some kind of a metallic cover at the carina. So otherwise, I think the techniques is good, and this is the sort of results that you will oftentimes expect from a DK crush. The angiogram results always look awesome as you do it well.
Please.
Do you mind if we move on to the OCT run that you have captured? And Chee Young? And of course, the other panelists, if there are any teaching points, please jump in.
We just did the pullback from the circumflex, so I'll start from distal to proximal. So this is in the proximal circumflex, distal to the stented segment. Here we see the distal stenage. There's a little bit of malapposition here, 12 to 4 o'clock, but that's very minimal and that should not have any clinical significance. So moving more proximally, the stent is well expanded and opposed. Okay. More proximally some more. Here there's, because of the underlying eccentric calcification, so we can see that the stent is not circular, but the areas should still be adequate. This is right at the ostium of the circumflex. You can see the LED coming in from the 11 o'clock position. Here we are in the distal left main. And the stent extends back to the guide catheter. So here we are in the guide catheter. The guide catheter is inside the stent somewhat. So we cannot assess the proximal edge of the left main stent at this point. So what Kay Woon and Benji are doing is they're inserting a guide extension catheter, the telescope, and we hope to show you how we can use that to better visualize the structures in the left main. While we're waiting for them to do that, I'll just do some measurements here at the distal ostium.
Telescope just come. Where's the telescope?
What are the numbers that you want to see, Chiang, for the ostiums?
Yeah, so I think classically the numbers that have been reported or suggested is the 5, 6, 7, 8 guideline, if you like. So 5 millimeters square at least in the ostium of the circumflex post left main bifurcation stenting. In this case, we have about 7.5, so that's definitely more than enough. So this is right at the ostium of the circumflex. This is the POC.
I don't need to see the. Oh, if you
definitely the areas are going to be adequate.
Yeah,
You can see the area is almost 12 millimeters square here, probably even more if I extend this a little bit more. Okay, so the areas look okay, yeah, although the stent is not circumferentially or concentrically expanded. But I think Kay Woon and Benji already went up high pressure, so this is probably as best as we can achieve. The OCT, I think, is in place for the next run from the LAD. So we will go ahead and do that first. Okay, so they've positioned the catheter right at the distal to the stent, so we might not have enough length, so we might have to do two pullbacks here, but nonetheless, let's do the first pullback first.
Okay, sitting. Okay.
So there was insufficient contrast blood clearance there. That's probably okay. We have the distal segment of the stent. We know we have to do a more proximal pullback anyway, so we can do the next pullback from the mid part of the LAD. So while waiting for that, let's have a quick look. This is the distal edge of the stent. The vessel just distal to it looks quite intact, so there's no evidence of any distal stent edge dissection. Since the catheter is still in the body, I don't want to waste any time here. So let's quickly do the next pullback before we finish our assessment.
All right. So come back more? Come back a little bit. Okay, that's fine.
So this is the guide extension to hopefully see the proximal stent edge in the left main, right?
Yeah, so the guide extension is in the left main. The guide catheter should be back down into the aorta.
Okay.
Okay.
Chiang, which guide extension works for this maneuver for OCT?
So we have here the telescope guide extension catheter. The telescope distal, I'll just go straight and show you that while I'm talking. Okay, so if you see here at this point, there's this bright kind of a ring, yeah? This is inside the distal tip of the guide extension catheter. This is the telescope. So you can see that the OCT is still able to penetrate through this distal tip, and we are still able to see outside of this guide extension catheter, which we wouldn't be able to if this was just the normal guide catheter. So the distal 2 millimeters or so of the guide extension catheter is quite light lucent. As we go more proximal, then we come to this area where there's some sort of like a coil, a metallic coil in the which provides the structure to the guide extension catheter. So this goes around and around. So we don't get an excellent view, but we still get to see kind of in between the coils. As you can see, we can still kind of see in between the gaps to assess the vessel outside. So this would have been even better if we had chosen the 54 millimeter slow pullback from the on the OCT, but because we needed the length of assessment, so we went with the 75 millimeter pullback. The 54 millimeter pullback would have given us more sampling per millimeter of pullback, so that will let us see better in between the the coils. I think back to your question about which guide extension catheter works for this, telescope definitely works very well. The other guide extension catheters like the Guidezilla and the Guideliner also allow us to see this distal 2 millimeters appearance. Yeah, so we can still see through the the distal 2 millimeter tip, but more proximally, I think their coils are maybe a little bit more closely spaced. So the ability to see through the gaps, see through the cracks here is not as good as with the telescope.
But actually, it's not too bad. Actually, I could see quite far back. Dr. Yusuke, are you still online? Do you have any comments on the imaging?
Yes, I can hear your comments. Thank you. So actually, based on the both imaging angiograph and the OCT, the result is very nice and a good expansion of the LED proximal and the circumflex. Sometimes we couldn't get the good expansion of the circumflex, but in this case, OCT clearly shows a good expansion and the apposition of the circumflex and no jailed stent strut at all. As the left main body, we can see the good apposition of the stent strut and the good expansion. I think in this session, the operator did a very good job, and maybe we, if possible, I would avoid to continue the long depth dual antiplatelet therapy because OCT image is very nice. It is my comment. Thank you.
Thank you very much. Kay Woon, I don't know, are you happy with your result? Anything else you want to optimize?
I think this is a very good image result. I think good expansion and the radiant circumflex. Actually, there is a little bit the calcified plaque at the behind the stent strut, but actually good expansion and a good area at the radiant circumflex. I don't any proceed. I wouldn't do the additional procedure in this case.
Thank you, thank you. OB-Van, can you unmute the care flag, please? Kay Woon, are you happy with your results? It looks fantastic.
Yes, very happy, Jack. Yeah, so I hope this is a useful demonstration to the fellows, this DK crush, the step-by-step evaluation of a patient that is unique and the challenges for each steps. I hope this clearly demonstrates the DK crush bifurcation technique.
Okay, so I think we take one last question before we close and summarize. Maybe Hui Chin can take this. You mentioned this and the audience asked, what is the reason of recommending to cross proximally in the second rewiring for DK crush? As we are aware, crossing proximally may create a new carina. Hui Chin.
Well, I think a lot of it is actually based on the bench study. So we actually don't ask that you go to the very proximal part, like in the first crossing, but going a little bit closer to the middle part of it will again ensure that you will have a stent coverage of the ostium as you go into a second kissing. So not the distal, but to the proximal to mid portion here. And all this bench work proven.
Thanks, Hui Chin. So I think we're at the last 10 minutes. Maybe I'll get some parting remarks from each of the panelists for their teaching points of the day. We'll start from the cath lab. Our two main operators, we didn't get a chance to hear from Benji. Benji, maybe share with us your one teaching point for the session.
One teaching point. I think imaging is very important. It optimizes the stent result. As well as it prepares your strategy at the start, whether you need to do any rotablation, shockwave lithotripsy.
So lab main intervention should be accompanied by some form of intravascular imaging. Kay Woon?
Yeah, as you go into lab-main bifurcation stenting more and more, the decision comes very technical, whether we do provisional stenting or two stents. And based on whether you're a follower of the European trial or the China trial, it may have different interpretation. Until we have more data, I think each patient still has to be individualized when it comes to the strategy.
Thanks, Chi Yang.
Yeah, I think I just want to echo what Benji said. Imaging is very important in left main interventions, and I think hopefully, as we have shown today, OCT in the left main is not, they're not mutually exclusive. You can still use OCT in the left main to get good images. Thanks.
Thanks, Chee. Charles.
Yeah, I think that the operators did a very marvelous job. I think that it's very important that we have to optimize our stent deployment and also make sure that the distal vessel, there's good distal flow like here. I think that it's very important that we stented the distal proximal to distal LED.
Thank you. Hui?
I think the team have done an excellent job, and then based on what the two lectures also are very nice lectures to give opinions for fellows learn how to optimize decay crush for left main bifurcation. I have no more idea. So just a question for all panelists and also the operators. Do stent designs make difference for left main result? So Onyx, Synergy, or Cyro, is there any difference between them when you perform a PCI for left main?
So maybe we'll get Giuseppe to answer the question then. Giuseppe, would you like to take the question? Does the stent matter? Maybe you'd like to unmute yourself first.
Pardon me, Jack, what is the question?
Does the type of stent matter? Is it Onyx, Synergy, Zymes? Does the stent matter for left main PCI?
So actually, based on evidence, the vast majority of the data derived from, the science, as you know, in Excel, we have different type of stents used from Medtronic, from the ABC and Rolex trial, etc. So I think that there are two global leaders. The two global leaders are science and probably the Onyx. And actually, what I think is that is important, at least, also in our country, consider the left main might be very big, more than 6, to have platform that may permit to cover also this size.
Thanks, Giuseppe. Dr. Giuseppe, your teaching point for the day?
Because we Japan, we are not so familiar with the DK class, but today I checked the DK class procedure very with the OCT image, and I think maybe the result only this is very important to because I have a good side branch opening, and we can do the DK class very safety with the OCT image with this the type of stent. I think this is my opinion. Thank you very much.
Thanks, Dr. Giuseppe. Thanks for being so honest about that. Professor Tan.
So Jack, I think this case illustrates what I always say: to have a successful PCI, you need the operator knowledge, you need his skill sets as well as his judgment. So that's one point. Second thing here is that I would like to ask the fellows to at least master 2 or 3 two-stent strategy well yourself. I mean, I don't have to learn everything, but I would imagine that the TAP and keloid and DK crush would feature in your learning process. And the third point with regard to the stent is that I think stent characteristics does matter in left main. I always go for a 3+1 characteristic of the stent. The 3 characteristics that I'll look for will be number 1, the radial strength. Number 2, the expansile characteristics. Number 3 is the side branch access. Then the +1, ± will be the radial opacity. I like a stent that is radial opaque enough for me to know exactly where my coverage of the stent is concerned. One of the points I just want to highlight here is that when we expand a stent maximally to its maximum, actually the stent does not shorten. The stent actually extend longitudinally, and this is actually illustrated in Gable-Torff Euro intervention, the bench study. So especially when you're covering the left main ostium and you go into very high pressure, be mindful that your stent actually expands by a bit more outside of the ostium of the left main. So the stent actually extend longitudinally instead of shortening when you take a stent to a high pressure.
But sometimes it's possible in practice to see also the opposite. That the reason for shortening sometimes of the stent also. You know, on the bench is like that, but actually in practice, I don't know if the other colleagues has experience in that we have a clear foreshortening of the stents. So probably one size does not fit all also in this situation.
Thanks. Prof Giuseppe, do you have any final teaching remarks before I summarize? Do you have anything else to add?
It's for me.
Yes.
No, I think we have covered all the aspects. I think it has been really a very nice, outstanding meeting, because we have seen, you know, in practice the step by step. You know, there was a bright lecture from Dr. Tan, a lot of great discussion touching all the points that are very useful for the intervention cardiologists, not just for scientists or for researchers, etc. So I think this has been, you know, my last word is that this is the way to deliver, you know, educational message with the focus of the left main. So thank you for having me on.
Thanks for your kind words, Professor Giuseppe. So I would like to close, and I'd like to start by thanking my wonderful panelists, my two lecturers, and particularly the Cath Lab at Heart Center, Kay Woon, Benji, Chee, and the Cath Lab team for such a wonderfully delivered case that made left main PCI look easy, which is not. So a few observations and take-home message for the Asia Pac audience. One, you heard my panel say that patient selection is actually utmost. At this day and age, I think the evidence still favor bypass for long-term outcome for left main location, especially complex bifurcation for long-term durability and results. I think particularly those with diabetes, impaired EF, other disease, high syntax score, I think we agree that you should take the patient off table, have a discussion, and not do this ad hoc. Because you do need some planning and some discussion about the risk-benefit, particularly with the patient and the heart team before coming back and doing this procedure. Technique-wise, I think I heard a lot of the evidence and the practical approaches. I think for the fellows, it's not just 2 or 3 bifurcation 2-stent strategy that you preferably should master. I think I'll add a third one, which is when you're starting out, I think I'll advise to choose the correct patient for a provisional strategy. And if you go that route, you do need the add-on +1 technique of a bailout strategy. I think if you're not comfortable with bailout, you should try to go for a 2-stent strategy and do it well, and then learn at least 2 or 3 suitable techniques, whether it's a DK crush, a mini crush, a tap, or some form of culotte strategy or reverse culotte. So I think you need to learn and understand the mechanics when you do a 2-stent strategy more than the type of 2-stent strategy. I think the confusion comes about the proximal crossing, distal crossing, but the take-home message is that everything else would be probably proximal and mid crossing, except for a culotte, where you try to go for a distal crossing in order not to create eyebrow sign or false carina. But everything else, try to go for a more proximal or middle crossing. I think that would be the simple take-home message. In this day and age, a 2-stent strategy, the most important step in my mind is a proper optimization of all the ostiums. That means proper port before any form of crush and a final port. And imaging is important to help you achieve that. So I was think that all the trials may evolve to a trial that shows that imaging will trump all the other outcomes in terms of techniques if it's mandated. So I hope to see that trial being done in the future so that we can continuously improve our left main bifurcation technique. With that thought in mind, thank you for staying the 2 hours, everyone, to the participants, and thank you for this extremely educational session. Thank you, and keep safe. Goodbye.
Bye-bye.
Thank you.
Thank you. Bye-bye.